Welcome to Sonographers in the Cities, where we connect through sound with your hosts, Lynn and Geselle. Hi, everyone. Welcome back to another episode of Sonographers in the Cities. I'm Lynn.
And I'm Geselle.
Thank you so much for tuning in to this episode. Today, we will talk about
Cardio.
specialties, right?
I was like,
Pretty...
what are we talking about? Yeah, specialties. That's what we're talking about.
Yes.
Actually, if you're in the beginning stages, this is great for you. If you're just tuning in about ultrasound, this is great for you. If you're already in it, it's still great for you, you know?
Yes.
Good refresher.
Yes. It's a good learning. It's one of the biggest topic in ultrasound when you're starting out. Because, how do you choose a specialty
Yeah,
when you
people don't
don't
know.
know what you don't know,
Yeah, people don't know
right?
that. I think the number one question we get on our social media is probably or like, how do you start? Where do you start? How do you begin? Kind of thing. And in order to do that, you have to actually choose a route, which people don't know that you got to choose a route. Like Lynn and I are both sonographers, but we do totally different things.
Yes.
And so that's what we're going to talk about today. What is your specialties, Lynn?
My specialty is echovascular. And what is your specialty, Giselle?
Mine is technically general, so everything else besides cardiac. And I also do vascular, which is the hard part because some places don't offer vascular with general. Some places only do general. Wow, this is already confusing already. With
Mm-hmm.
you, they also call echovascular cardiovascular or
Cardiovascular,
cardiac
yes.
sonography, cardiac.
So
Because
there are two names
people
for
are confused.
echovascular because
Yeah.
when you're a registered cardiac sonographer, you do echo, you're a registered cardiac sonographer. And when you're vascular, you're a registered vascular technologist because that's what your our credentials are. So technically I have two labels.
I was gonna say, can you explain that? That's confusing. Gee, cardiac, echo, same thing. They mean heart, right?
Yes.
Dealing with the heart.
Yes.
Vascular, anything, veins,
Just the veins, arteries,
arteries.
the vascular system.
But do you do TCDs?
No. That's also vascular, but that's specific to neuro. Because I
Ah,
have a
okay.
friend that does TCDs all day, every day, because it's specifically neuro.
Okay.
But we do learn TCDs for the registry and to get our credentials. It's just part of it's under the vascular umbrella.
I was gonna say they do TCDs under vascular board exam.
I
So
think I
do you
think
have
there's
that?
some private practice that does TCDs.
Mm-hmm.
It's just, in a vascular lab, TCD is not part of it.
Okay. So you'll find cardiovascular sonographers, vascular technologists in both hospitals and outpatient
Yes.
clinics, doctors' offices. I think cardiovascular, cardiac specifically, echo specifically, are more in
Outpatient.
doctors' offices. Yeah, outpatients, right?
Yes.
Okay. That's my assumption. I am not a cardiovascular sonographer, so I can't speak behind all those things, but
Most of the time it is outpatient because, cardiologists would order an echo. Most of the time it's routine checkups and all that stuff. If it's inpatient, most of the time it's just check on the heart when the patient's admitted for something else, just to see how the heart functions, or any specific procedures like TEE, which is transesophageal echo, which is where you put the probe down your esophagus to look at the heart. And that's done by the doctor with a cardiac sonographer in the hospital.
I had one of those done.
Oh, yeah? How was it?
Yeah.
Were you like
I
half awake?
I freaked out. I was no, I started like freaking out and they're like, you're gonna be okay. And then they knocked me out and then
Oh,
I
okay.
woke up and I got a popsicle after.
Oh, they give you a popsicle.
Yeah, my throat was hurting. I guess that camera goes
Yeah.
down your throat.
Mm-hmm.
Crazy. So what are you doing
Yeah.
as this procedure is going on? You're just kind of doing the machine stuff?
Yeah. It's the doctors that inserts the probe, and then the sonographer is the one that like takes the images, they're on the
Yeah,
machine, adjust the TGCs and all that stuff. Yeah.
that's cool. So, I mean, as people probably don't know if they're not in this yet, ultrasound has procedures and stuff. So, as a cardiovascular sonographer, is that the only kind of procedure you guys have? Or do you guys have other procedures?
There are other procedures too, like vein ablations. If you guys, work in or know anyone who works in vein clinics, that's the one of the most common procedures you will see. Vein ablations is where you get not varicose veins, but your superficial veins are not working well. They close up the veins so that you won't get worsening symptoms, basically. So that's one. I personally have never seen it because the labs I'm in doesn't do it. We usually do like post procedures just to check to see how the procedures went and just to like follow up. The only one that I've done in person was pseudoaneurysms. Like if there are positive PSAs, that's when you do the probe and then the doctor would insert the needle to inject the thrombin to close up that pseudoaneurysm. That's like the only procedure that I've done. And other than that, the vascular lab, we don't ever we do a lot of like follow-ups or pre-ops, not
Yeah,
much procedures like generals. I'm sure you have a whole bunch of procedures.
yeah. But with cardiac too, do you guys use needles?
We use
That's a question
needles.
people have all the time.
So for echoes, we do use needles to use what's called a contrast, which is not really a contrast. It's an echo. I explained it to my patient today. My brain is blanking out. It's an echo enhancer. It's a
Ah,
lipid solution that is injected through an IV to brighten up the walls of your heart so you can see the
ooh.
walls of the heart better.
Hmm.
Most of the time, you can ask the nurse to put in the IV with the consent of the patient because the patient can always deny it.
Yeah.
And the nurse, or if you're certified to insert the IV yourself. So that's the only needles you do.
Wow.
I mean, the only needles I use personally is the blood needles to draw up that contrast.
Uh-huh. Oh, okay, okay. Because you don't
Yeah.
actually put the IV in.
Oh, absolutely not.
Okay. That's interesting. I get a lot of questions about do you use needles? And then how about blood? Do you see blood in
Blood.
cardiovascular
Yes,
sonography?
when you take those IV out, sometimes the blood squirts. I had a patient last week who was a bleeder. She bled through the gauze that after I took the IV out. So I put on another gauze and she bled through that one. So I had to call on the nurse who had to apply a pressure, what's it called? A pressure,
Like
I'm blanking
you're
out.
applying pressure to the area?
Yeah, so she was applying pressure, but she bled out through her gauze. Usually we
Mm-hmm.
use gauze and then we tape it up or a band-aid, but she
Mm-hmm.
was
The
bleeding
little cup
beyond.
thing that you put on? The little cup pressurizer thing that pushes on a vessel?
I'm not sure, but I had to call
Mm.
the nurse and she had to do like a pressure thing where she uh basically put on the patient's arm and it was like this big.
Yeah, it's like
And
a
the
big
patient,
thing.
yeah, and the patient had to be sit there monitored by her for like 10 minutes.
Uh-huh. Hmm.
That's the most blood I've seen.
Yeah.
But other
But
than
but
that,
typically you don't really see blood on the daily.
no. On the
Okay.
daily, no. The only time you see blood is, when they insert the IV, when they take out the IV, or if I do PSAs, if you're in inpatient patients with, if they've had a procedure done and you're scanning over that area, stitches might get broken and patients bleed, but that's it.
Hmm.
But sometimes blood actually works better than gel as a medium for stain.
Oh, wow. I wouldn't think
Yeah. Fun
that
fact, by the way.
would. Huh. So then, I mean, cardiovascular, you're pretty much scanning hearts all
Yes,
day and
all day.
veins and arteries all
Veins and
day. So
arteries.
arms
Yes.
and legs all
Arms
day.
and legs.
Okay. Anything else?
Carotids,
Oh
the
yeah,
neck.
carotids. I forgot about
You
carotids.
can't forget the carotids.
Oops. Yeah, carotids in the neck.
Um, Abdomen, visceral, areas, which is the aorta.
Okay.
Depending on the labs, renal arteries, which are
Oh,
very tough.
I didn't know you guys did that too.
Renal arteries for vascular is different than renal arteries for general testing.
Oh,
Um, Veins in the legs. I think that's it.
that's pretty much it. Like if someone was to like, oh, what am I gonna expect as a
Yes.
cardiovascular sonographer? That's pretty cool.
The downside of it is that if you do vascular, you get stinky feet. I know some people can't stand feet at all. So
Yeah. So
yeah.
yeah, feet, chest, like you're gonna see people's breasts, right? Because
Mm-hmm.
like the heart, people have large
Yes.
breasts. So you have to be comfortable with
Right.
touching patients in
Mm-hmm.
those areas.
Yes.
Thighs, groin area,
Groin areas. Yes. Um, I was gonna say
armpits,
something.
the
Yes.
axillary
Yeah, you get in
region,
there. Echo, you get in there too, because some patients hearts are like up here.
up high, up in the chest or
Yeah,
in the
very
side.
high.
You
Mm-hmm.
gotta have windows and stuff. So
Imaging through the ribs.
it
Yeah,
is interesting.
you don't get a lot of bodily fluids
Okay.
like general, but
Mm-hmm.
you do get other things.
Yeah.
I think you have to figure out what you're okay with.
Yeah. So that's a pretty
What?
good basic basis of
Mm-hmm.
cardiovascular. Anything else you want to share about cardiovascular?
Cardiovascular. You're basically looking at um for echo for cardio, you're looking at one organ, very, very complex organ.
Yes.
It may sound boring because you're looking at one organ, but the heart is very complex. You're looking at the chambers, you're looking at the valves, you're looking at how blood flows, you're looking at pressures in the chambers, you're looking at how blood flows out of the heart, you're looking at how blood flows into the heart and how that affects the rest of the body
And
from
the
the heart.
heart does not look like this.
No,
Just to let you know.
everybody's heart is different. Sometimes it's like this, sometimes it's like this, although it shouldn't look like this.
Yeah. Like hearts all look different and like they have different issues and you're
Yes.
looking at all these different things. And so people tend to think that cardiac would probably be an easier route because it's just the heart. But would you beg to differ?
I think all routes are hard. It's depending how you look at it. Because
Yeah.
again, the heart is one organ, super complex. You got to learn it inside out, flip it upside down. And then there's the vascular system where you got to know the arteries, which I think vascular is simpler than echo because you're in one spot of the body and you're in either transverse or sag, you're measuring velocity and you're looking for plaque or stenosis or occlusions.
For
And
blood
then
clot.
when there's or blood clots, yes. And then there's general where you got so many organs in one specific spot. That's also complex too, because you got to know so many organs in the orientation of where they are in the body and what is the normal and what is abnormal, right? This is a good lead into your specialty.
Yeah. Cardiovascular. So interesting.
Yeah.
Well, I guess we can move into general.
Mhm.
General sonography. So for those of you who want to do ultrasound on babies, because that's what everyone goes into this for, you would
Mhm.
go into general ultrasound. It's called general because it's got everything else that is not the heart or the veins. So that's what the rest of your abdomen, that's like your organs, your liver, kidney, spleen, gallbladder, pancreas. That's also women's health. So your uterus, your ovaries. It's also men's health, testicles, and um,
Prostate.
prostate. Yes. And then you've also got musculoskeletal, which is like soft tissue. We do stuff for like hips, looking for fluid. We also have a ton of procedures. So biopsies, bodily fluid procedures. We call them thoracentesis, paracentesis. It's to remove fluid from around your chest, remove fluid from around your belly. There is also what I would say is basically just the rest of the body. So I like if you just scan the rest of the body besides the vessels. Now, if you go into general, some programs will also include vascular and some will not include vascular. So the program that I went to was a general vascular program. Now, I do vascular too. So everything that Lynn was talking about in vascular, I actually know how to do, as well as she was talking about the ablation studies. I could do those too. I've done some in my doctor's office. So it's it's a lot, but it's also very different, and you learn things, just like per chapter, right? You learn things about the GI system. You learn about the carotids one day. You learn about the brain one day. It's a lot of information, but you learn it. You learn normal anatomy, and then you learn abnormal anatomy. You take it out to the field and you scan whatever the doctors order, because that's typically what they do in an emergency room or like in a hospital setting. They'll say, okay, this person has elevated kidney functions. Can you check their kidneys? So then we check their kidneys. And a lot of protocols include the aorta IVC, the bladder, and then other protocols don't. Just depends where you work. As far as the needles go, we only really work with needles during procedures. We're not actually using the needles, but we're opening the trays for the doctors. We're setting up the trays for the doctors. I've actually worked at a place where we actually like put the needle in for the lidocaine and draw it for them. But like not a lot of places do that. It's usually the doctors do that. But just know you might have to deal with that. Other than that, we don't really use needles. And then blood, you will see blood because we deal with OBGYN, vaginal bleeding. A lot of people go into the ER for vaginal bleeding. They'll order a pelvic ultrasound. And then also with like IVs in the arms or the legs, if you work at a place with an ICU, you're going to see a lot of body parts. It's different to work in a hospital versus a clinic, but there's ways where you can work at a clinic and not see those things. But if you work in a hospital, and I think you should, because you learn a lot in a hospital. And even if you do your
Definitely.
clinicals, yeah, if you do your clinicals there, you'll learn a lot more there than you would in a clinical site. But not saying it's bad to just do your clinicals at a clinic and then just stay at a clinic for the rest of your life. Like you could do that and never see a hospital setting, never see
Right.
blood. But it's what makes you a better sonographer at the end of the day. You see all these different things. So yeah, basically general vascular is everything else. Um, abdomen pain, leg pain, arm pain. We do the renal artery stenosis scans, which is the kidney Dopplers. So I didn't know that vascular would be different than general, but I'm sure protocols, like there's always different kinds of
Protocols are
protocols.
a little different. Like for renals, do
Mhm.
you look at anterior views and flank views, or do you only
Uh,
do flank views?
we just get it wherever we can get
Right, because you're
it.
an inpatient, right? In
Yeah.
inpatient, it's just you're limited.
Even in the outpatient setting, what I did was, if you have to get the segmentals and the
Right.
arcuates and the main renal vein, main renal artery, and they just get it wherever they can get it. So there's no specific way you're supposed to do it.
Mm.
I don't know, that could be not right,
I think it
but that's
depends
what
on,
people do out
I
here.
think what I noticed from teaching in the school with working with the general sonographers who are professors there, and from my experience in a vascular lab, how they approach renal arteries is a little bit different. And um, I think from my experience with renal arteries, we're looking for specifically stenosis, right?
Mhm.
And the protocols that I'm used to is like you have to get anterior views where the origin of the arteries to the aorta in anterior views, like transverse of the aorta. And
Mhm.
then you also get in flank views so that you can
The
see the
side.
sag part too. Just
Yeah.
like super thorough. Maybe it's the protocol, like super
Yeah,
thorough.
it probably is.
And also another thing with renal arteries is that patients could get FMDs, which is fibromuscular dysplasia. That if they get it, it would be from mid to distal renal arteries.
Mm-hmm.
And that usually when you get that, you most likely have FMDs in your carotids as well.
Mm.
Yeah.
We're learning things, guys.
Yeah. I know
Yeah.
this is like what's this? Sonographer talk, but just a
Yeah.
glimpse.
But that's kind of interesting though that you say that because I know that our protocol, we get proximate distal aorta. I mean,
Hmm.
proximate distal main renal artery, but wherever we can find it. But because it's
Yeah.
always really hard in
Right.
patients, they're not always your perfect kind of scan. So
Mm-hmm.
it definitely is hard. Like a lot of people do not like doing renal artery stenosis exams, especially because their kidneys
Because they're so
vessels are
deep,
small. Yeah, they're
small
small
and
and
deep.
deep. And you'll learn with ultrasound that things that are superficial, so like, musculoskeletal stuff or things that are higher that you can see, like your left lobe of
Close
your
to the
liver,
surface.
that's easier to scan than things that are deeper.
Right.
So I think that ultrasound is very interesting. And knowing that there's lots of different specialties is really cool because you can decide which route you want to go, and you can even do all of them if you want and be called a full body sonographer.
Right.
So the thing about it is, before going into a program, you have to choose the route because there's a cardiac route, cardiovascular route, a vascular route, a general vascular route, and you got to figure out if your school even offers that route.
Right.
And it's like, what are you talking about, lady?
But I gotta say though, I think vascular is getting very versatile because for vascular, if you start with vascular, you can go into echovascular or you can go into general because what I noticed a lot of job posting now is they, especially for general, they require RDMS, but then RVT 1 year later. I don't know
Ah,
if you've noticed in your area, but I noticed a lot in like New
your
York
area.
area. Yeah.
So I heard or learned over my career was that in the East Coast, it's more of a departmental, like you've got your cardiac department, your vascular department, and
It's
your general department.
yeah.
Like I heard that's what they do out there. Is that correct?
Yes.
So in Vegas, you're either cardiac and you only do cardiac, and you probably know vascular, but you only work in cardiac, and then you're general vascular because every single place I worked at, you need to be general vascular as far as a general sonographer in the hospital setting, or even outpatient, actually. All the little radiology departments that do, like, doctors' offices send their patients to these radiology clinics, they're general vascular sonographers. And cardiac is all in doctors' offices. And there are vascular labs out here, and then some doctor's offices that just do vascular. So it's really good to do, honestly, vascular plus either cardiac or vascular plus general.
I don't know. Maybe if you don't want to do babies, vascular could be the way to go for now until you decide which route you want to take.
Yeah, because I
Right.
mean, that's the first thing that people think of is babies, right? So,
Right. Yeah.
like, if you already know you want to go into for babies, general and do vascular,
Mm-hmm.
to help you out. Because then, if you're tired of just scanning babies all the time, you can always go into general because they don't teach OBGYN by itself.
No.
OBGYN is a part of general, and you have to learn everything else with OBGYN. Who knows? Sometimes you might realize you don't like OBGYN.
Mm-hmm.
What's your favorite? Is cardiac or vascular part your favorite?
Oh my God, that's a hard question because I do both. Scanning wise, right now, vascular. Only because I'm doing echo 4 days a week and vascular 1 day. So I'm missing vascular a little bit. But talking about it, like learning about it, I love echo. Like I could talk echo all day, every day, talk about the heart because I love it.
Yeah.
My
Oh,
coworker calls me echo nerd. So
well, that's
yeah.
good. I mean, you're interested in it, right? And that
Yes.
that means you picked the right route for
Hmm.
yourself.
Yes.
And for me, I didn't get to pick. I mean, my school just had general vascular, but I also forgot to mention that general has breast as well. So those are pretty much like all the registries you can take: cardiac,
Right.
vascular, abdomen, breast, OBGYN, musculoskeletal, and then there's pediatric, which is a very, very, very specialized one. And then
Yes.
fetal echo, which is also very specialized.
Yes.
Did I miss any?
I don't
I
think so.
don't think so.
If you want to do neuro, it is under peds pediatric
Yes.
sonography.
Yes. They used to have their own, but now neuro is under pediatric. So if you want to do neuro, go into general vascular.
Yes.
And then you can, but like I said, you still have to learn everything just to
That's
do
true.
TCDs. Just to do TCDs all day, you have to learn everything because you have to get the pediatric board exam. Pediatrics is under general.
Do you
So
learn TCDs in general too?
it's more vascular, I feel like.
Right. Because we
Um,
specifically learn TCDs in vascular. I don't know if,
yeah.
yeah. So basically, this is
Because
so weird.
it was in
So
it is in
if you want to
vascular.
do TCDs, you would do vascular,
Uh-huh.
right?
Yep.
And then sit for Pete sonography to
Which
do
is
TC.
general.
Yes.
Which the
Uh,
thing is though, they also have a TCD certificate. So you can do the certificate way of getting your TCD certification because there are different kinds of
Right.
TCDs. There's like have you seen the blind TCD machines?
No.
It's like they don't use the actual ultrasound machine. They use a blind TCD machine, which is
Hmm.
older, like more outdated version of it, but
Hmm.
they it's like a little probe and they just use the machine and they click up and down according to the depth
Uh-huh.
of where it's supposed to be, like where they're scanning. Versus I like the ultrasound version of TCDs because you can see where you're at. You see landmarks, you see vessels, you can tell on ultrasound.
Yes.
Um, but that's good to know that I guess vascular is a very, very like advantage if you go that route.
Hmm.
And then just kind of do your research on seeing whether you would like cardiac better, like scanning the heart, or whether you'd like general better.
Right.
Every day is different for both specialty.
Yes.
Um, and they're both challenging, they're both difficult.
They're both complex in different ways.
And honestly, I liked vascular a lot more than general when I was first learning.
Hmm.
So I feel like vascular, because it's just so straightforward, like you said
It
earlier.
is very straightforward. Like
Um,
sag is sag, transverse is transverse. Arteries and veins are different, you know. You can't
mhm.
miss it. But
Yeah.
if you miss it, then, it's not there.
And I know that with general, there's so much you got to learn with
So much.
every organ,
And every
every,
pathologies,
yeah.
like you have to know it in your head to rule it out when you scan. That's a
Mhm.
lot.
And I'm sure you guys have seen the protocols that the OBGYN sonographers out there on social media post. They
Hmm.
show all the things that they look at in a baby. That's a
Hmm.
lot of things, and I don't want to do that. So
No, I don't
I
want,
don't want to
yeah.
deal with that. So that's why I don't do like second, third trimester OBGYNs in a
Hmm.
doctor's office because those are very complex too. We do very limited exams.
I heard the beep.
You hear the beep? My husband is making birria tacos.
Ooh,
Okay, the beeps are done. He's making birria tacos, so our hot pot or instant pot just went off.
you are so lucky.
But
He makes such good food. You know what I was missing?
uh,
I miss his that fish he made when I
oh yeah, when
went
you guys came
over.
over. Yeah, he
Yeah, that
loves to
was good
cook.
fish.
So you
Yeah.
gotta come over soon.
Oh yeah, let me hop on my plane and fly over there.
But yeah, on your next PTO vacation break, if you ever get one.
That I don't get because I'm full time.
If you guys didn't listen to our last episode, we're talking about per diem versus full-time life.
Yeah, that was our joke
But
for last episode.
Yeah.
Anyway, back to what we were
So
talking about.
yeah, it's
Oh,
a lot. Just
yes.
choose which one
I
you
I
like
just thought
more.
of something. If you want
Mm.
to do fetal echo,
Hmm.
like you can go both route. You can go the OB route, which is general, or you can go the echo route, and then you can cross train to fetal echo.
Why are you confusing them more? No, just kidding.
I know, right? But what
Just
if
kidding.
someone's listening and they specifically want to do fetal echo? This
Yeah,
is for you.
there you
I
go.
thought of you,
Fetal echo, which means what?
which means doing echo on the fetus, which is an unborn baby
Yes.
inside a mother's belly,
Yes,
i.e., just
because
like Giselle's belly.
because there's two different things, right?
Mhm.
Scanning a baby while they're in the mom
Yes.
versus scanning the baby's heart outside of the mom.
And that became Pete's echo, which
There you
is
go.
a different way of scanning.
Because
So
you're touching that
echo,
baby itself now.
yes.
It's
So
born.
echo, adult echo is a different way of scanning. It's upside down. And then Pete's echo is right side up. And then there's fetal echo, which is whichever way the baby's lying.
So confusing.
It is very confusing.
If you guys have any questions, let us know. Send us a DM, comment below.
I
We
hope
really
I didn't
like
scare them off echoes.
we really like your guys' comments and seeing them and your
Yes.
messages. It is a lot, yeah. But honestly, like we didn't know any of these things before going into ultrasound, right?
Yes. Hmm.
So look at all we know now. And if we could go back, would you do it differently?
Nope.
Me
I
neither.
I haven't regret. I think if I went to general, I would have regretted it.
Really? Oh yeah, because you were originally
I was
general.
originally general and then I switched the day before class starts.
Yeah, well, if you were originally general, we wouldn't have this podcast. I'm just
I
kidding.
don't know. Maybe we could we'll be both generals.
Yeah, because we were like, wow, this is so good. You do cardiac vascular and I do
Right. Yeah.
general. So it works out. But yeah, it's all good. It's all ultrasound at the end of the day and
Right.
just try to figure out, do your research, ask questions. Don't go into something just because someone told you something. Like you have to look it up for yourself and figure it out for yourself. Because
Yes.
for one person, they're gonna love OBGYN. Another person, they're gonna love doing breast ultrasound. I hate doing breast ultrasound.
Why?
It's so
Why?
hard. Oh, I also forgot about the
Oh,
thyroid.
oh, do you do
We do
like
thyroids.
do you do the clock like nine to
Uh-huh. That's how they're scanned. So the breasts are scanned as a clock. So imagine a clock, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, 4, around the clock.
Mm-hmm.
And then um you measure like centimeters from the nipple. So
Mm-hmm.
depending on where you're finding it, it's
Mm-hmm.
very complicating, but depending on where you're finding it,
See,
you
even
you
the breast is
say,
complicated.
yeah, you say it's uh you whatever you found was at like 1 o'clock, 2 centimeters from the nipple, and
Mm-hmm.
then you have to measure it in two different planes. And then if you find it on one exam, you're gonna follow it up on another exam. Um, and for me, it's just a lot to do, especially like in outpatient places, because you have to follow what that last person scanned. So if the last person scanned and found like 20 cysts, you have to follow them up.
Oh my God.
Yeah, it's
That
a
sounds
lot.
awful.
But there are some places that have better protocols.
Mm-hmm.
There are some people who love scanning breasts. I don't knock them, If you love that, that's
Have
awesome.
you ever
That's
scanned a breast phantom?
no, actually, I've never scanned any phantoms. We didn't get any.
No. So the school I taught before had breast phantoms.
Mhm.
I had never learned breast, so this was my first time. It looks I we call it a chicken cutlet because it looks like a piece of chicken breast.
Ah,
Yeah, it's just like a
just like a
slab
beep,
of chicken breast and then
and you
you
just
sit
scan
on your
it.
skin. And it has full of pathologies in it. It's really cool.
Oh, that is cool. Breast is hard. It's like finding a needle in a
Yeah.
haystack. You
Just
know,
yeah.
thyroids are hard. It's the same thing. I mean, it's like the protocol is not hard. You know, it's like scanning
I
is not
think
the issue. It's
the
the
thing is,
abnormalities.
once you find the pathology, the abnormalities, and have to be consistent with the patient's priors, that's the tough part because you
Hmm.
never know what the last person did, how they found it,
Hmm.
you know.
Yeah, it could have been a different way they position them, you know.
Hmm.
Thyroids can be kind of crazy because there's nodules and cysts and all these things, and you got to measure all those. Testicles can be hard because patients don't like it when we scan, obviously, their private parts. Like it's a difficult
But
thing to
especially
do.
when they're like, in pain too, and you like try
Hmm.
to push, like I
Yeah, so that's the
just
thing. If you
yes.
don't want to do those, just go to cardiovascular.
But
Or
then with echoes, you have to scan, you know, you gotta fight the breast in women and the chest in men
yeah,
just to get
so
to that organ underneath.
this is why you need to do your research,
Yes.
and figure out what you might like. The people in OBGYN, they don't have to scan scrotal exams or thyroids or kidneys because that's the route that they chose. And yeah, I mean, do your research, and we're here to help you guys. So thank you so much for listening. I hope it was
Thank
a fun
you.
one.
Hope it was an
Uh,
informative one. Not to make
and
you any more confused. Hopefully not confused.
yeah, I think it's more so to help you guys kind of see what the
Yes.
real, what you're gonna really be dealing with. Because like you
Right.
don't want to go into it being like, whoa, I
I
didn't
didn't
sign up
realize
for
it's
this.
like this pretty
Yeah.
much.
Yeah, I didn't realize that I had to like go in between the breasts, or I had to use a needle for something, or
Right. Or
see
gotta see
feet.
blood.
I say feet, you say blood.
I know.
But yeah.
Right.
So we hope you guys have a wonderful day. Let us know if there's anything else you want us to talk about. And thank you for listening.
Yes, thank you. And until next episode.
Bye.
Bye.
Hey, SITC fam. If you like what you're hearing, don't forget to rate us 5 stars on any podcast platform. Leave us a review wherever you can. And don't forget to subscribe to LL Giselle on YouTube. Follow us on Instagram and find us on Facebook at Sonographers in the Cities.